And welcome, Padraic and Dani. Padraic's our program manager for ePharmacy, and Dani is the pharmacy advisor. And you can go into any details that you want with regards to your role and give us an update on where we are with ePharmacy and moving to digital in that area.
Okay, well, thank you very much. I'll do a quick share of some slides here, and we'll get the ball rolling. So, can everybody see those? Okay.
Yes, we can.
Okay. Okay, the ePharmacy program. And first of all, just by way of introduction, who are we? So, first of all, I'm Padraic Tunney. I'm the program manager for the ePharmacy program. Just a little bit of background. I started off life as an accountant, transformed into IT project management, and then spent about 16 years in the consulting world, covering a whole series of different areas around change management, project and programs, system implementations, etc., and made my way into the health service in 2018. So I'm only here a relatively short time. So that just gives you a quick overview of myself. So over to Dani.
Hi, my name's Dani, and I am the ePharmacy advisor for the programme. I am a pharmacist by background and was in England for 15 years up until about 2.5 years ago when I came back to Northern Ireland to take up this role.
Okay, thanks, Dani. Just to say, first of all, the most we can do today is give you a whistle-stop tour as to where we're going with the ePharmacy program. There's a lot in it, and we're happy to engage separately with anybody who needs to or wants to engage with us afterwards in terms of the specifics. So we'll rattle on and move through. So first of all, a message from our SRO, Kathy Harrison, Chief Pharmaceutical Officer. So basically, ePharmacy is a transformational program for the HSC, and when it completed, it will transform the experience of the patients, the public, and community pharmacy and wider healthcare system in terms of pharmacy. And it is also a very important component of the community pharmacy strategy for strategic plan for 2030. So that's included within that plan, and some of the objectives in that plan are aligned with the delivery of some of these solutions.
Sorry.
Please help yourself.
Sorry, there's a mic open somewhere in the background. Just want to check that. So what is the ePharmacy program? It is ePharmacy will transform how community pharmacy services are delivered in Northern Ireland, and it will facilitate service growth. And it's really around digitalizing the clinical service delivery within community pharmacy. So that is your and Dani will go through the detail on this later, but that is your minor ailments and so on and so forth that you go to your pharmacy for clinical support. The electronic transfer of prescriptions, and then the third major project within the program is the replacement of the current prescription validation system, which is critical in the context particularly of putting it in a position to receive electronic scripts. So that's at a high level what we're trying to achieve. And I'll let Dani talk through some of the detail against each of the individual projects.
Yeah, so as Padraic said, there are a number of projects in the ePharmacy programme, 4 to be exact, and the first is the Go Pharmacy NI project. So the aim of this project is to deliver a digital solution for the delivery of community pharmacy services. Community pharmacy currently deliver a number of HSCNI services to the public that would have previously been delivered by GP practice or out of hours. So an example of this, as Padraic said, would be the Pharmacy First Everyday Health Conditions, which deals with quite a number of minor ailments. So the project also aims to provide a patient-facing website to signpost patients to what services are available through community pharmacy and which community pharmacies provide those services. The second project within the programme is the Electronic Transfer of Prescriptions project, so the ETP project. The aim of this project is to provide a digital solution for the transfer of prescriptions from a prescriber to a community pharmacy, and then the onward transfer to BSO FPS for reimbursement. Our third project is the electronic prescription and eligibility system, also known as the ePES replacement project. This project aims to replace the current prescription processing and validation system. Prescriptions are processed through ePES before they're then transferred over into FPPS for reimbursement. The new solution will also facilitate the consumption of electronic prescription claims. Padraic alluded to that in the previous slide. Our current ePES cannot consume electronic claims, so therefore one of the big reasons for needing a replacement system is around the fact that we need it to consume electronic claims. So our fourth and final project is the Drug Master File project. And the aim of this project is to deliver a stable solution to manage the prices and fees that are set out within the Northern Ireland drug tariff, and map these to the internal BSO codes and the National Dictionary of Medicines and Devices codes, which many of you will probably know as the DM&D. DM&D are the standardised codes that are used across the UK 4 nations to identify medicines and devices in the NHS. So although these are 4 separate projects, they are all intrinsically linked. So the Go Pharmacy NI project cannot be delivered without the ePES replacement project, nor can the ETB project. And without the Drug Master File project, the ePES replacement project cannot be delivered. As an estimate for all projects included in the programme, we have about 85 million in for what we believe the programme will need to complete. Next slide, please, Padraic. So the programme itself meets all 6 of the digital strategy core strategic outcomes. For each strategic outcome, I'll give you an example of how the programme will meet these. So the very first one would be the ETP project will provide patients access and community pharmacy services with greater visibility and control over treatment and care journeys by enabling patients to nominate and amend their preferred community pharmacy for dispensing of their prescriptions, while also providing visibility of their prescriptions through the journey from prescribing right through to collection. It will also meet outcome 2 by providing a digital solution which will improve patient experience, and in particular for out of hours patients. So out of hours will be able to have their prescription sent digitally to their preferred pharmacy over weekends and evenings, rather than having to travel to an out of hours location, potentially hours away, and then try to find a community pharmacy open over the weekend. Such circumstances, unfortunately, are regularly occur, and these situations are actually hardest when it comes to end-of-life care. And as part of outcome 3, we will provide joined up care and support services through system integration and streamlined information flows by enabling sharing of the community pharmacy patient record with the GP clinical system and Epic Care. This will provide a fuller patient record for healthcare professionals across HSCNI and enable improved decision making. Outcome 4 will be achieved by automating the current manual process for the transfer of prescriptions, removing the need for pharmacies to collect prescriptions from GPs, batching them, reconciling paper prescriptions, couriering the prescriptions to BSO, and then BSO scanning every individual paper prescription into the validation system. This will enable our people to work more efficiently across standardised systems. Outcome 5 is all about the provision of the intelligent use of data to optimise performance and harness population health and insight, whilst ensuring data protection standards. Through Go Pharmacy NI, we will be providing live data as consultations are carried out in community pharmacies. This will enable SPPG, Pharmacy and Medicines Management Team, to monitor services without having to request paper copies of consultations from individual pharmacies, and it will allow them to digitally analyse the data. It will also enable ad hoc analysis if issues arise and improve data protection through digital rather than paper records. The programme will support the acceleration of research and innovation by providing detailed analysis of prescription and community pharmacy consultations in a live environment. Currently, information is limited due to the manual recording and is not timely, being available 8 to 12 weeks after payment and analysis. So as you can see, the programme as a whole meets all 6 of these strategic outcomes. Each project will have its own business case and each outcome will be highlighted within that, but just as a whole, the programme does meet all 6. Padraic, you're on mute.
Thank you. The other thing to mention in relation to data sharing is that all of the information in here will be available to be transferred into NIHAP for analysis and research at a much higher level. So just to give you some idea of timelines, at this moment in time, we are in the process of pulling together all of the appropriate business cases, particularly for the 3 larger projects. So we're hopeful that we can have drug master file completed and ready by 28-29, in line with GoPharmacy NI. And in order for GoPharmacy NI to complete in 28-29, we need to have that project rolling during 25-26. The EPES replacement then falls into 29-30. We've just commenced this year the preparation of the business case around that and got a project board in place for that particular project. And again, in order for it to complete in 29-30, we would need to be commencing that in 26-27. And then finally, ETP is for final completion in 31-32. And again, in order to deliver that, we need to be getting that rolling from 26-27 onwards. ETP, I suppose, is the final part of the jigsaw, but it is also the one that's going to take longest to implement. And looking historically at how it has been implemented in England, where I think they started about 2008 and have been operating various iterations of it since then. We spoke to Estonia, who implemented over a 5-year period. And we're talking to Wales at the moment, who are taking the English solution, and they've been planning and working on this for about 3 years, and they've just commenced in the last 6 months a phased rollout, a phased 3-year rollout, which it make it a 5 to 6 year project as well. So that gives you an indication of the timelines, and there's an awful lot of work that needs to be done between now and then. So moving on to why we need the program. So, well, as we referenced earlier, it is very closely aligned with the Community Pharmacy Strategic Plan for 2030. But at a high level for ETP, we manually handle through from prescribing through dispensing and all the way through into final payment, 25 million scripts per annum. And that's, I think, equates to about 45,000 separate script lines. Because we are manually handling, we've got the risk of losing, misplacing, and we don't have the capacity to track scripts, and it's very difficult for scripts to be turned around and safely cancelled whenever, before they get through to community pharmacies. As Danny alluded to, acute scripts cannot be transferred quickly to the community pharmacy for dispensing. All scripts must be issued, paired, printed, and on special secure stationery, which is quite expensive. Community pharmacy have to, once they gather all of their information and do their dispensing, they've got to hand code each individual script. And throughout all of that, from beginning to end, you've got significant manual processing all of the way through. So it is something ETB has been around in England, now rolling into Wales, and it's been around in different parts of the world for quite a while. So it's coming a time when we need to get it implemented here in Northern Ireland. So I'll hand over to Danny for GoPharmacy NI.
Yeah, so just for some context, all other areas of the UK have digital solutions for recording of their pharmacy services. And really, everything that's on this slide is the reason why. Currently, there's about 800,000 paper documents manually handled for community pharmacy services annually. These range from paper consultation forms through to paper claim forms. And it's extremely difficult to increase the complexity of services within the current paper-based system. And the main reason for this is really the fact that there's no link back to the patient's health and care number. So the transfer of patient information either doesn't exist or isn't in real time. So when a GP practice does receive information, it could be 48 hours after the service has been delivered, and it will be in paper format, which will then mean that the admin staff in the GP practice have to scan this onto the patient record. So again, it's not reaching the patient record in any timely fashion. This then increases the risk of service duplication, both within GP practice and community pharmacy. So community pharmacy have no means of knowing what services have been delivered by other pharmacies because, again, it's all paper and it's stored in those pharmacies that have delivered the services. Now, from a service monitoring perspective, consultation information is held within the community pharmacy and only minimal data is collected on a monthly basis and mainly to ensure accurate payment. So when full service monitoring is undertaken, it involves the scanning or posting of copies of these documents into SPPG local offices. So that information is then manually input into spreadsheets by our business support colleagues and passed through into the relevant pharmacy advisors for review. So not only is this really time consuming, it means we don't have access to all consultation data for full monthly analysis. It's also current, as we said back at the very beginning, it's really difficult for patients to know what services are currently provided in community pharmacy and then what pharmacies actually deliver those services. There's no single point of access for this information and patients are relying on pharmacies to advertise these services. One of the biggest risks we all know with paper-based systems is, as Padraic said, the misplacement and loss of paper. So there's significant information governance risks with the transportation of paper between community pharmacy, GP practices and SPPG. So another real benefit to community pharmacy is that from 2026, pharmacists will be qualifying as full independent prescribers, and this will bring additional clinical opportunities to community pharmacy sector. But without the IT infrastructure for them to prescribe, this could severely hinder those opportunities, and this could then lead to workforce-related constraints, as these pharmacists will go to other pharmacy sectors if they can't continue to progress and use those clinical skills that they have developed prior to qualifying. Next slide, Padraic.
Sorry, okay, I'll cover off the EPES, Danny. EPES replacement. The EPES system is the system which processes all of the scripts. ePharmacy at the end of the month send through return scripts that batches and send them through via courier. Sorry, can everybody hear me now? Okay, that's better. So the yes, as I was saying, the scripts are currently sent through physically and are all scanned within the EPES system at this point in time. So at this point in time, the contract has expired or will be expiring soon in relation to the EPES system. We continue to have a statutory obligation to accurately pay a community pharmacy. So therefore, we need to have a replacement system in place. From the point of view of the programme, particularly, the EPES system, the EPES solution is not designed to receive electronic scripts, and any new system will need to be designed in that way. Again, from a technical point of view, there isn't the number of environments that you would need for a modern system. There isn't a pre-production test training environments in place in relation to EPES. There are some poor operational controls around EPES, bearing in mind that the system was written, I think, originally back in 2005, 2008. And so it's difficult to actually monitor and control where elements are within the system. Because of the age of the system, there is a potential for system failure. And then because time has passed, there's a lack of knowledge. There's a lot of knowledge that has been lost over that whole period of time, both internally within HSC&I and also within the provider of the system. that has meant that it is difficult sometimes to understand what's happening under the bonnet. So that's a quick overview as to why we need to implement ePharmacy in the context of the 3 projects within it. Just moving on to try to get a fix around benefits. So as Danny mentioned earlier, we're in the process of going through and preparing the business cases for all of these projects, and we're at different stages with the different business cases. At the moment, we're just sitting down to look at what the benefits of ETP and EPES actually are and working through that with stakeholders. So we haven't solidified all of this, but we have been able to utilize some of the slides or some of the information that's available in England around what they used for their benefits whenever they were putting EPS in place. So the first one, England didn't have any cash releasing benefits at all within their EPS business case as it was then. But we have been able to draw out the cost of printing the individual scripts and also the cost of couriering. So we have pulled together an estimated figure based on the fact that at some point in time we would hope to get to about 90% coverage of scripts going through the electronic route. So that gives a very high level indication. Numbers need validated, etc., but we would hope that there would be some cash releasing savings coming from this. When we look at the savings that England have had, and we have prorated these back and adjusted them slightly, but the major non-cash releasing benefit is for GP practices, particularly around the fact that they no longer have to physically sign a script. They don't have to physically cancel the script. They don't have to spend time chasing around and monitoring, trying to find out where a script is if it's left them and hasn't yet arrived in community pharmacy world. It also reduces the amount of time for repeat prescriptions. So there's a whole series of benefits that come with for GPs with ETP, and that was certainly the biggest benefit that was highlighted in England, and we would hope that it would also follow through here. So the second is around patient experience and safety. Again, we have utilized some of the numbers from England, non-cash releasing benefit, but it's really around the benefit to the patient of being able to get their medication faster. Also, the capability of being able to cancel scripts and redirect them and so on and so forth throughout the whole process. In terms of HSCNI prescription efficiencies, it's a relatively small number. Again, it is non-cash releasing because our expectation is that, yes, there will be some efficiencies within HSCNI in terms of handling prescriptions. But in addition to that, we will also have to stand up the new system, and we'll have costs associated with monitoring and administration around that. So that number has been tempered back. And then in relation to the community pharmacies themselves, again, we have tempered back the England figure because, in fact, England had to deprecate some of their numbers around community pharmacy because there is a requirement within community pharmacy to dispense medication safely. And what they require is that they have a piece of paper to move around as scripts are actually physically being dispensed in order to get all of the approvals and the governance around that. And while when you move to ETP, there will be no physical script, so therefore they need to find some methods and processes by which they can manage that dispensing process carefully by having a piece of paper or a script or a token or a barcode label make its way through the pharmacy with the in terms of picking the actual drugs themselves. So that has been tempered because there will be some additional costs associated with that, and that was something that when England were pulling their benefits together and reviewed them at a later stage, they had to deprecate that area. But at a high level, prorating what England have and also tempering some of those numbers, we're potentially looking at 14.9 million of non-cash releasing benefits coming through that. the hope is certainly within GP world that some of that time that they're able to save through that efficiency process can be put back into the ability to see patients with much more complex healthcare needs, and likewise from an admin point of view, to be able to be in a position to address the massive demands that are coming on top of GP world. Thank you. I'll leave GoPharmacy NI to Danny. We are at a slightly different stage in GoPharmacy NI in terms of the benefits, so we have a little bit more detail in what we can provide.
Yeah, as Padraic has kind of alluded to throughout this, from a benefits perspective, it's actually very difficult to produce measurable benefits when you're moving from a paper-based system to a digital system. In a number of cases, there are multiple things that we know GoPharmacy NI will improve, but without a baseline, it can't necessarily be used as a benefit. So a perfect example of this would be patient abuse of services. So we currently have no means of knowing how often this happens or preventing it. The GoPharmacy NI solution will prevent many cases of this because we are providing a shareable patient record. However, we have no baseline on which to measure it, so therefore it can't be part of our benefits realisation. But just a few, we pulled out just a few from our OBC, and really, there's quite a lot of opportunities that are being missed within the community pharmacy sector. So through the GoPharmacy NI solution, we would aim to be releasing about 35,500 GP hours a year through the delivery of additional services, and that would equate to about £607,000 per year. So in both England and Wales, community pharmacy deliver what's called the discharge medicine service. However, without the proper IT infrastructure, this has proved almost impossible for Northern Ireland. The evaluation of the discharge medicine service in Wales has shown that there is huge potential in reducing both A&E attendance and hospital admissions because they are picking up medication errors at the point of transfer really quickly. The GoPharmacy NI solution would allow for that IT infrastructure to be in place to fully deliver this service. And when you take the Wales data, as we've done with the NHS England data for ATP, and you apply it to Northern Ireland, it would equate to approximately 10,000 consultations per year that could be undertaken, and that could reduce £142,000 in A&E attendance and £1.9 million per year in hospital admissions through the identification of medication errors at source. So as stated before, it's extremely difficult for patients to find information on the services which are currently available through community pharmacy. So by delivering a patient-facing website to signpost patients to appropriate pharmacies, this would increase patients' access to service and therefore their experience. At the minute, unfortunately, sometimes what happens is the GP practices know certain services are available. They will tell a patient, oh yes, you can get that in pharmacy, go to your pharmacy, and unfortunately they get to their local pharmacy and their pharmacy doesn't deliver that service. It's the pharmacy on the other side, the other side of the town that delivers that service. So it's really difficult then for patients, and actually then you're not building trust with patients, and you're not using those services to the best of their ability. So you'll not be surprised, but due to manual nature of processing and monitoring community pharmacy services at the minute, there will also be the ability to release HSC&I staff to carry out additional monitoring and added value work, which they haven't been able to do currently. So as a whole, GoPharmacy NI benefits, as much as they have been difficult to undertake and put together, there is so much potential in what GoPharmacy NI can provide for patients in Northern Ireland. Over to you, Padraic.
Well, just to give you a sense of some of the challenges, and these are but a few, and that we've got to try to overcome before we can implement. So one of the key challenges we have is around community pharmacy connectivity to HSC&I. And I think that is absolutely critical for the ETP solution particularly. And because we are starting from a very, very low base, we do not have any We do not have accreditation of any of the patient medication record schemes or record systems patient medical record systems that are used within community pharmacy world, the PMR systems that are used to dispense. There's no accreditation at all of those in Northern Ireland. And we don't have community pharmacies signed up to any form of data security protection protocol. They can access the network at the moment, but the majority of what they do is on a read-only basis. So they can safely do that, but we need to be able to share data with community pharmacy world, particularly for ETP. We would also like to be in a position to share data on GoPharmacy NI as well. It would give us the capability to increase the functionality around that. So this area is something that has proved to be difficult in England, certainly when it was set up in the first place, and Wales are going through this process at this minute in time. And we have started on this process as well, because we have started to engage with all of the PMR suppliers to try to understand the systems that each supplier has in place, and also to try to understand what the IT network is and what the IT landscape looks like within community pharmacy world. And then we in turn will have to go through the process of verifying all of that with our colleagues within infrastructure and coming up with a set of rules and regulations around what level of data security we need to have, and also around the accreditation of the individual systems to allow those systems to connect and actually receive data. The other area that is critical in here is that all of in order for ETP to work, all of the PMR systems that are running out there in community pharmacy world, and there are 5 or 6 different systems supplying over 500 separate pharmacies. There will be modifications required to all of those systems as well, and that's a significant piece of work in terms of getting that modification done to bring all of those up to standard. So that's one of our major challenges, which is something that Wales have been working on, and it's one of the reasons why they are in a 3-year rollout, just to get all of those systems up to speed, on board, and functioning, and accredited. The second point is around business change. There is significant business change with this. This is a significant transformation, and we need to be working with all our stakeholders to, I suppose, paint a picture of what the future will look like. What we find generally is that most of our stakeholders, the first question they will ask, well, what will it look like for us? And we need to be working with our stakeholders in order to understand the impact of what we're talking about, and ensure that we build all of those impacts and all of those requirements into our actual system data requirements, so that we will get the correct set of requirements in, and we'll get the correct solution up front, and that everybody will have a key understanding of that. And we're working with a range of stakeholders, not only from within HSCNI, but also external to HSCNI, and all of the stakeholders involved have got different motives and different motivations and drivers behind why they want this, and why it's going to be of benefit to them. So just to give a very high overview, we talked about GP practices. I mean, for ETP, they will have no longer have, hopefully, physical signatures, but on the other side of that, there's a whole identity management and authentication, which we'll come on to in a second, which is going to be required for GPs to operate. So that will be a change for them. On the opposite side, from GP point of view, hopefully they will have fewer clinical services to be delivered because they've moved to community pharmacy, but then they're going to need to change and refocus their mind on how they address patients with higher, more complex needs. So there's a piece of work that needs done with GP practices. Community pharmacy probably will have one of the most significant changes to all of this. Their ETP processes will change. Hopefully they will no longer need to be putting a vehicle on the road to go and pick up scripts from GPs, and hopefully they won't have to go through the whole process of bundling up all of their scripts at the end of the month, because they'll be able to claim that through their system. But on the other hand, they will need to address the issue that I spoke about earlier in terms of how they manage their whole picking process and how it might have to change in line with the new systems coming down the line. And we need to work all of that through. In relation to GoPharmacy NI, community pharmacy is delivering maybe 15, 16 separate services, and as part of our process, we have already gone through a change impact analysis against all of those services to try to work out, what it will look like in the future, and to really particularly bring community pharmacy, give them a feel and a sense for what it's going to look like going forward, and then we can utilize that to embed those changes throughout the whole process. Danny alluded to some of the changes that business support and SPPG PMMT may have, and that is around their ability to, hopefully they will not have to process, particularly for GoPharmacy NI, they will not have to process lots and lots of paper in terms of approving payments, and hopefully they will not have to deal with lots and lots of paper in the context of monitoring services, but they will need to change some of their roles to become much more focused on the validation and monitoring, much more focused on data analytics and drawing all of that information out in order to understand what's happening and improve processes. So again, it's a switch in focus for them. And just briefly to touch on BSO-FPS, we mentioned it earlier that hopefully there will be some efficiencies that will flow through there, but by the same token, BSO-FPS will probably have to look after a lot of the administration side. So again, there's potentially going to be moves of overall responsibilities there. So it is something that we need to be on top of, and we need to be on top of it not just whenever we start to go live, but we need to be on top of all of this throughout the whole process of building the business cases, getting the approval, and then writing the requirement specification going forward. The third one is around identity management, and we will have to implement a really strict identity management set of processes, particularly around the digital signature. So there will need to be 2 or maybe even 3-factor authentication applied at the point whenever the digital signature is being applied to the scripts. And there's a very stringent process around that that needs to be implemented, and will be. It'll also be a bit of a change, particularly for GPs, because of the identity management and the restrictions around the identity management and the signing that is required for them. And then finally, funding, which is an issue for, I'm sure, every single project and every single person within health at this moment in time. There are no assurances around the capital and revenue in the future, and we are waiting just at the moment to get assurances around funding for our team for the next year or 2 in order to get the business cases developed and get them to the standard that we can actually start and implement. So I think that's us for today. I think we've got about 15 minutes for questions. So thank you all very much for listening. And as I say, there's a lot in this, and if we need to pick up with individuals, we're quite happy to do so afterwards.
Thanks very much, guys. That's great. We do have some questions in the chat. So Danny, you mentioned other nations having digital solutions in place. Will you look at those and consider those models?
Yeah, so 2 nations in particular, England and Wales, actually have 2 very different models. And when you look at the English model, there's about 11,500 pharmacies in England in comparison to our 500 in Northern Ireland. And in Wales, there's about 700. So when you look at how they deliver their services, England have this kind of supplier accreditation system in which you can accredit your system through NHS Digital, which means they have multiple solutions that can be used for the delivery of services. And that's fine when you have that infrastructure in place, when you have those accreditation processes in place. But the likes of Wales there, they didn't have that. They have about 700 pharmacies. What they did was they procured and built their own solution. Which from a Northern Ireland perspective, we would fit that model much better. When you have 500 pharmacies to then have to try and manage multiple suppliers, it's not the most effective use of time really, when the procuring of a solution that we control would be a better option. If you take the Pharmacy First agenda in England that should have went live in November, but actually ended up being delayed till February, all because suppliers were not ready. And even when it went live in February, the suppliers, although stated they were ready, it then transpired after launch that actually there was a number of key issues with those systems, and it wasn't just one system, it was multiple systems there was issues with. So again, I think there's a real advantage to using the Welsh model for a Go Pharmacy NI solution and procuring your own solution for use within Northern Ireland, one solution that is used by all community pharmacies that we have the control over. I hope that answers your question.
Okay. Dawn, there was Dawn Bowers that asked that question. So if you want to ask any more, or you have anything else, any other queries, just shout.
Yeah, no, that was great. Thanks, Danny. That's grand.
Can ETP and EPES be solved with a single solution? Don't know who we want to go to there.
I'm not sure. Yeah, Gary, I think I don't believe it can, but I think it's something that we can maybe have a conversation offline to explore, put it like that. I mean, ETP as a solution, whenever you break it down, it will end up combining a whole series of different elements. It's not just one solution. You know, you've got messaging in there, you've got your identity management in there, you've got the playing in of and the interfacing with all of the other systems and the external systems. So I think the requirements on both are different. Could they be provided by the same provider? Quite possibly, but they are different systems. But I think we can pick that up in a conversation at a later point, if that works, Gary.
Oh, thanks, Paul. I got no real knowledge or answer to it. It just seemed that one part of it. It seemed like two parts. The start and the end point of the same thing. I was just wondering if there's a way to join them.
Yeah.
I think the difference is, Gary, so the Northern Ireland drug tariff dictates the rules and fees for payment within Northern Ireland, and that's updated monthly. So, you know, our ePay's solution, a lot of the time, the rules and the fees and everything are applied monthly. There can be changes to that on a monthly basis. To do that through ETP would be a real challenge, you know, to have that flexibility and that fluidity that's needed, because, you know, you would need that. It's kind of separate entity.
No, that's perfect, Danny. And I say I wasn't a loaded question. I didn't know the answer, so thank you.
Okay. Thanks, Gary.
I know as part of the presentation, you had commented, Danny, on just you know, cash release and things like that. And Alan has just commented there about the significant environmental benefits as well with the reduced printing. So that's certainly a plus. Gary has come in with another one there. Given the week that we've had this week with Belfast Go Live for Encompass, will Encompass be fully considered as part of the holistic solution?
Yeah, I can take that one. Yes, they have. Or they're in the process of being, shall we say, for Go Pharmacy NI. They're actively looking at that. We went out recently with a revised RFI in relation to Go Pharmacy NI because of the passing of time and other new thoughts that have come along in the 2-year period. So Encompass stroke Epicare are currently reviewing that at the moment for Go Pharmacy NI. We had discussions with them around ETP also, but they felt that was an infrastructure project and it's something that they couldn't look at. And we haven't got to EPES just yet, but they certainly are in the mix and are in consideration.
All right, thank you. I kind of did know the answer to that one, but probably just good for the rest of everyone else to know the detail behind that and the consideration of what might happen. Thank you very much.
Okay.
Is ETP last in the programme because it is dependent on the other projects to put building blocks in place? Sounds like GPNI is putting some of that infra in place.
Okay.
The infrastructure.
Yeah, partially. We need particularly we need to have a repository for our scripts. So EPES replacement absolutely has to be in there before ETP goes live. But the time frame for implementing ETP is also pushing it out to the end, because it is much more complex, and the history in terms of delivery around the world shows that it takes 5 to 6 years to actually implement an ETP solution. So there's a little bit of both in that, Alex. I'm not sure about maybe we can have a chat about GPNI is putting some of the structure in place. I'm not sure, maybe you've a follow-up on that one. I'm not sure I'm not sure about that element of the question, Alex. So.
Oh, no worries. No, it was just I thought maybe my question was getting answered as I was typing it. So
yeah,
went earlier, and I thought, oh, flip.
Yeah. No, that's fine. Thank you very much for that.
Other plans for ongoing funding for maintenance and understanding of the systems going forward in light of the current systems losing the underlying knowledge?
There are negotiations going on, discussions going on at present with the provider of that system, just to make sure that we get assurance around that continuing until we're ready to go with the EPES replacement. So that is being addressed in terms of getting that knowledge understood and getting it out there, and making sure that if we do need to extend that contract, that it's on a much more robust basis going forward. So yeah, that is happening.
And how do we solve the problem of pharmacies still wanting or needing to print for picking purposes?
I was going to say, I don't mind taking this part.
Okay.
So essentially, we can't solve the problem. It will be up to their system suppliers. So essentially, there are system suppliers out there who use what we would refer to as a paper-light solution. So instead of printing a full token or a full script, what they do is they print a label with a barcode and the items on to pick. Now that is a much better option than potentially having to print a full script. That seems really counterintuitive when we've just made it electronic. So essentially, we can't really solve the problem, but what we can do is incentivize the means in which suppliers are spec'd. So in other words, we could incentivize a paper-light system. So if you have a paper-light system, then you could get potentially a little bit more money. So there's ways of incentivizing it. Wales have kind of worked around incentivizing that that stream of work, because again, they feel the same way as us, that really, it's an electronic prescription, we should be going down a paper-light or paper-free option. So they have incentivized it. So there are options around it, but ultimately we can't solve the problem ourselves. It will also be a supplier-led kind of negotiation.
I think we have commenced, as I referenced earlier in the discussion, with one of our key challenges is around community pharmacy from both a technical point of view and from the PMR solutions, and getting those amended. We have started the process at this moment in time with those providers and have had discussions with them, and gradually we will evolve to trying to have discussions with them as early as we possibly can, because there is time over the next couple of years. Some of the suppliers are indicating to us that while it's too early for them to go fully paperless for Wales, they are starting now to plan to do that. So they won't have it necessarily immediately when Wales go live, but they have got development plans to move that direction. So hopefully by the time we get to the point of rollout, a lot of these providers will have moved much more towards a paper-light, if not a paper-free solution for picking, because that's ideally, if we could get to the point where we can have little or no handling of paper all the way through, then that's really what we're trying to achieve.
Great, thanks. I'm not saying anything more in the chat. Padraic, if you wouldn't mind, oh, there is one more. If you wouldn't mind, stop sharing.
Okay, yes, I'll do that.
Just so that there actually has been another one come through the chat. Have we looked at the solutions in Southeastern Trust? And now the Belfast Trust pharmacies have put in place for the picking issue with a paperless system?
Again, the difficulty there is the fact those are our people and our solutions, so we can indeed we have control over that process, whereas this is community pharmacy and they have control over their systems, so we do just have to bear that in mind. There is, as I said, we can incentivize, we can put forward the options that are available, but ultimately the decision does lie with them and their supplier.
Will there be a paper-based system for non-medical prescribers, e.g. dentists, or will they be included as well in the programme?
You want me to take that one, Danny?
I don't mind.
Yeah, no, they at this point in time, because dentists and ophthalmic and others do not have a prescribing system solution within their applications, then at this moment in time they are out of scope. However, if dental systems are developed to include a prescribing module, then absolutely we want them in scope, because we want any system that is any prescriber that's out there who has a digital prescribing system at this point in time, we want them in scope. But our understanding at the moment is that certainly dentists, ophthalmic, and some others are don't have
they're all handwritten.
a digital. They're still handwritten, but it's something that we'd be happy to discuss if there are developments in here that we're missing.
Thanks very much, guys. I just wanted to hand over to the floor there. If anyone, wanted to come in and ask a question, put your hand up or just come off mute and come in. Raymond has made a comment there just in the chat. It's quite appropriate that you were just back on again, Raymond.
Sorry, I missed it. It was a great presentation. Thank you. But I can watch again, can't I?
Yes, you can indeed. Yeah.
Thank you.
If no one else has any questions, then yeah, we can wrap up. So as I said at the beginning, this has been recorded, so we will get it subtitled and put it up on DHCNI TV. Usually we issue a little bit of a promotional article around everyone on the intranets and in newsletters to say that it's available and it's there. But if you check in week after next, hopefully it will be completed and up. I'd just like to thank Padraic and Danny for presenting today. Really interesting subject, and thanks very much for everyone joining. Thank you.